Good afternoon, everyone. This is Lynette Elliott. Thank you for joining us today. It's May 14th, and you are on the Gravity Project Community Meeting. We will go through a few regular administrative items, and then we'll go through our agenda, and I will hand it off to my fearless team members to take over from there. If you are new to these calls, we do have a lot of back and forth discussion in the background during the presentations and the Q&A portions where we open it up for anyone to speak or ask questions. If you would like to pose a question or comment during the call, you can use your chat feature. Please send it to everyone because there are several of us and many of the other community members who can probably address your comments or questions while we move through the presentation. And we've had some very lively discussion in the last few weeks, so please keep that up. Next slide, please. This is our antitrust policy. We put this in here because we are an HL7 fire accelerator project, and that's one of our governance requirements. You can review this. It's in each slide deck that we post on the Confluence following the meeting. Next slide, please. If you have not already done so, if you have not joined the project on Confluence, please do so. You can be a committed member or an other interested party. And we appreciate all levels of participation. There's never any charge. It's a public collaborative. Committed members are asked to review deliverables and provide feedback, and you can vote on those deliverables as well. And at the point that we get ready for another end-to-end review on the data set that you're walking through right now, you will all be asked to do so. Other interested parties can comment as well. They are not expected to vote, but that's basically the difference between the two. And you will also, if you are a joined member, you will also be added to our email list so you can receive project updates and calendar invitation updates directly from us. Next slide, please. These are our project founders and our in-kind supporters. We have many organizations who are supporting this work, and we deeply, deeply appreciate it. We can't do this without all of you. So if you are interested in becoming one of those sponsors, next slide, please, you can express your interest either on Confluence. There's a big blue button on the landing page right under the announcements where you can submit an interest form, or you can email us at gravityproject@emiadvisors.net. Next slide, please. These are the things that we're going to cover today. We have some announcements, and we'll show you the project roadmap and upcoming schedule. We update you each time so that you know where we are in the big picture as well as from week to week. And then Linda's going to provide an update on the housing data concept submissions. She's been adjudicating those with the help of Sarah DeSilvi and our subject matter experts behind the scenes. And then Sarah will take you through a debrief on diagnoses. And then we'll open a discussion up for interventions, professions, agencies, and organizations, and provisions for those. And then at the end of the call, we'll just zip through some homework and next steps for all of you. Next slide, please. We have a virtual Connect-a-thon that's taking place right now. Some of you may be part of an organization that is participating in that as we speak. The general information is available on the HL7 site. You can see this link. It's actually on the Confluence. And then there has been a Google Doc that has been set up so you can track the actual progress and the notes that are coming out of the Connect-a-thon activities. So you don't have to furiously scribble this while it's on screen. You can go to our Gravity Confluence after this meeting, and this will be posted. Typically, it's posted by the end of Friday. Sometimes we get it up there earlier, but sometimes we don't. But it'll be there within 2 business days, and you can go to that Google Doc and see some of the things that have come out of the testing activities that are being done right now. Next slide, please. There are also other upcoming events. There's a care coordination track. This may be of great interest to many of you, and it includes the Gravity use cases. There's information about that on Confluence, the HL7 Confluence. And there's also another upcoming virtual Connect-a-thon here in May for MyHIN. That's an interoperathon, and you can go to these links. Next slide, please. We have stood up a COVID-19 and Gravity collaboration site. It's a blog. You do not need to have a login if you want to just view it and read what other people are saying. If you would like to contribute to that conversation, you will need an hl7.org login, and you can request that at the HL7 JIRA, which is the link right here. It's very easy. You just request a login, you submit credentials, and it gets approved, and you confirm in a little email, and you can post your own comments in the blog. And we would appreciate as many of you doing that as possible, because this is an open conversation, and we are looking for collaboration in the social determinants of health space as it relates to COVID. Next slide, please. This is our schedule. Most of you have seen this before if you've been on these calls. We're here on 5/14, and our deadline for data element submissions for housing instability and homelessness were due last week. If you have been scrambling, like most of us have been, and still want to submit concepts, please do email us. You can email gravityproject@emiadvisors.net and just give us a heads up that you want to submit something, and we will still accept it. It's very important that we collect as many of these as possible. Even if you've passed the deadline, there's forgiveness, because we all know what's happening out in the world. So do communicate with us if that's something that you want to do. And then the next time we meet, we will be going through the same things, and we should have an updated calendar from that point so that we have a better sense of how we're moving forward. Next slide, please. This is our overall snapshot of all the things that are happening for Gravity. We're doing the domain work at the same time that Fire IG development and testing is going on, as you can see. We are in Q2 of 2020 and won't be for much longer. Actually, are we in Q3 now? No, not quite. Still in Q2, but you'll see this bar as we move through. There will be, as we finish the data set identification, then we'll be making coding recommendations, and the fire implementation guide development will continue as we do that. Next slide, please. Linda, I'm going to hand it off to you at this point to update us all on the domain data concept submissions.
Great, thank you, Lynette.
Welcome.
You should all be familiar with this slide coming up. This is our submission summary. Actually, since our last call, we received several more submissions, so we're up to 13. And as Lynette said, if you've got some items you want to send to us, we're still happy to accept them. So we have our overall summary at the top of all the total number of data elements across all 13 of those submissions. And we've reviewed 9 of them. We still have a few more to review, and we've returned 4 of the submissions. So you can see clearly, actually diagnosis and goals went up this week, which was great. We've been asking for more of those. And interventions is also up. Screening tools, we're getting a number of tools that are duplicates of the ones we already had, but that's great because that also gives us a sense of how many organizations are using which of those tools. Just a reminder here for those of you who submitted, when you do get your email back from us and you go to the the adjudication dispositions, this is some definitions for what you're going to see for those statuses, just kind of to help you figure out what happened to each of the elements that you submitted to us. Just a nice little visual of all the organizations now who have sent us a submission, and we don't mind making this page, adding more to this page. So please go ahead and continue to submit if you have something you want to add to our master list. And I believe this is again just how to review that master list, as Lynette said after the call, and we put all of our material together. You'll get that email that gives you the links for the recording, and it will also give you the link to get back to the most recent master, which will show all of the new adjudications we've done in the last 2 weeks. And this is just the link for where you can go to find the master at any point in time, whatever version is out there, you can still see it. And I believe, yes, now we're going to turn this over to Sarah, and she's going to talk first about debriefing on housing diagnosis codes.
Hi, everybody. First of all, I want to thank everyone for coming. I know some people are going back and forth between the Connectathon and this meeting today. So there's a lot of gravity happening at once on this day. So thank you for coming. So in the next few slides, we're going to present some of the complexities of decisions that go on when we adjudicate. I'm going to remind folks about gravity process. So the community submit concepts that they think need to be built into data. The subject matter experts collectively review them, and then whenever there's things that need to be discussed that aren't really cut and dry, we bring it back to the forum and we discuss it with everybody all together. So I'm going to briefly go over what we discussed regarding housing diagnoses last time, and then do some level setting going forward. Next slide, please. So these slides are from the last time we met. So I'm going to briefly describe again how housing insecurity is a different thing entire than food insecurity for a couple reasons. So when we worked on food insecurity, there's a standard validated tool, which is the USDA food security module, which creates a commonly understood spectrum of disease, of concern, I should say, from mild to severe. We do not have that replicated in the housing insecurity world. There is no comprehensive tool. There is no real agreement in severity. What we do have in housing insecurity right now is a general concept of housing insecurity and various subdomains, as we're calling them. So homelessness, history of homelessness, overcrowding, doubling up, housing instability, multiple moves, at risk of eviction, behind on rent, and inadequate housing. So these are all concepts that you can easily glean from the public health literature that looks at the health outcomes of housing concerns that are found in social needs screening. Next slide, please. So again, I want to put this slide up here. So we really have done a pretty comprehensive gathering of questions when it comes to how to screen for those subdomains. We included the entire 2019 housing survey, housing insecurity supplement. It's massive because it's in development. So this is the seed of what will eventually become a housing security module for HUD. Because it's the seed, it is they're just testing lots and lots of different questions to see how they fit. And eventually it'll get winnowed down to what they find to be necessary. So it contains almost everything. We also have Children's Health Watch comprehensive survey, prepare. We have the housing, inadequate housing questions that are in the Accountable Health Communities tool, which was pulled from a study in Connecticut by Naruzaman et al. We have the VA homelessness tool, we have WellRx, we have We Care, we have Health Leads, et cetera. So between all of those submitted screeners that we have so far, we do cover every single one of those subdomains that we found in the literature. Part of the reason why we had to go again to the American Housing Survey is specifically in the concern of COVID. Again, there was insufficient questions in our set to cover concerns of doubling up or housing. So we wanted to go and gather more. Any questions so far? So this is just basically on what we had presented last time. So it sounds not, okay, so I'm going to keep on going. Next slide, please. Oh, actually, we have one more slide. So last time I presented a basic outline of what it might look like if we took existing codes in ICD-10, which are homelessness and inadequate housing, and structured parent and child concepts with those subdomains, like where would behind on rent, multiple moves, at risk for eviction, doubling up and overcrowding go. And we had a lovely conversation regarding that. Some of the complexity is that there is differences of opinion about where these different concepts go in that parent and child relationship. And as we think ahead into building these concepts into terminology, we have to consider how they belong and how they fit together, because that's how they get fit into the taxonomy. So That then brought me to a series of meetings with subject matter experts on how to solve this problem. And that created more questions, which is great. Oh, is overcrowded defined by HUD or in a definitive way? It is, there are multiple definitions of overcrowding. We base our definition on the HUD definition, yes, but that is a very complicated concept. We had a conversation about this last meeting, that there are cultural norms when it comes to overcrowding that complicate risk factor identification. Part of the reason why overcrowding is important right now is because capacity to self-isolate, given the COVID use case. Overcrowding is different than doubling up, which has a different definition. All right, so I hope that answered your question. Yes, it did. Thanks, Lucy. Okay, next slide, please. Okay, so I had a series of meetings with different subject matter experts, most notably and thankfully with the principal investigators of Children's Health Watch in all of their different sites. Children's Health Watch are our SMEs in general. I'm grateful for their insight at all times. And then they have sites across the country looking at the effect of social needs and many different social concepts on young child health and parental outcomes. One of the questions they asked, which I realized that we hadn't really done yet, and for this I apologize, is really discuss what is there. And this is, we're going to talk about this for a few minutes. So with food insecurity, there was only that one code, Z59.4, lack of adequate food and safe drinking water, to cover everything, as I say, from Flint, Michigan to food insecurity. And that is very clearly not defined enough. One of the things I feel like we neglected to do was basically lay out to the community the ICD codes and the SNOMED codes that already exist in the terminology as it stands right now and how they're organized. Because it may be that housing is so in development as a concept that we actually are not able to suggest anything definitively for new code, because the moment we suggest new code, we have to define it and agree on it, come to consensus, and then disseminate that definition. So the next slides are going to be me basically laying out how ICD and SNOMED is structured right now, and then hopefully having a conversation about what those gaps might be. And this is building off of our conversation from last week. Next slide, please. So I'm going to start with a description of the Z59 set. So Z59 in ICD is the general parent is problems related to housing and economic circumstances. So within that, you have Z59.0, which is homelessness, Z59.1, which is inadequate housing, Z59.2, which is discord with neighbors, lodgers, and landlord, Z59.3, which is problems related to living in a residential institution. And it should be stated that this literally means that you live in an institutional setting, whether that be in a elder adult facility or in institutional housing as a young adult. That's how that's defined. I grade out the non-housing related concepts here. So I grade out lack of adequate food and safe drinking water, extreme poverty, low income, and insufficient social insurance and welfare support. And then there's this general bucket code. So the way it works with ICD, and we have lots of intelligent coding experts on the call today, of which I would never claim to be. I'm a novice in this world, I do my best. Is that you have the defined elements and then you have other defined elements. So other problems related to housing and economic circumstances are defined, but not covered by the general codes above. Any questions regarding this before we proceed? No. Okay, I'm gonna keep on going. So then what I decided to do, just to get everybody on the same page. So the question that we ask ourselves is, can we say the things we need to say in healthcare terminology? And if we can't say them, what do we need to say in order to take care of patients well? So right now, what we're going to go through is a series of slides that detail for the whole community the existing ICD codes and then the SNOMED problem list codes that are mapped to it within both SNOMED and the National Library of Medicine. The reason why this is important is one of the concepts that we raised at the last meeting was it's possible to leave ICD the way it is and build the granularity we desire within SNOMED as a first step in our data build. So you could find that granularity in a patient problem list. It could be transferred as part of a concurrent care document, but it would not necessarily be in claims in the level of granularity that it is in the problem list. And we know this throughout healthcare. This is the way many things are. So Z59.0 maps to SNOMED concepts of homelessness, housing lack, homeless family, homeless single person, or lives in a squat. And I do want to say these maps are maps that are made by coding folk, and they're not necessarily consulting subject matter experts in that domain. It's just a best guess, right? But they do a pretty good job. Okay, next slide, please. Oh.
Quick question.
So this is Sarah. This is Sarah. Hi.
Oh, sorry, Sarah. Sorry. Quick question. When you say problem list, you mean like health concerns / problem list, I assume, not just sort of physician level coding, right?
I mean the area in a health record which is determined to be the problems that are defined for the patient from both from a form or meaningful use perspective and from like a concurrent care document perspective. Like I'm trying to understand. And is this Jo Ellen? Who's talking?
Julia Skapik from NAC.
Hi.
Okay.
So yeah, so I mean the problem list as it's defined, but the SNOMED codes are all throughout health records. So do you have thoughts regarding that?
Because, in the sort of larger care plan kind of framework, the problem list is sort of the clinician managed list of things, and then the health concerns list includes the problem list and expands to allow anyone, including the patient, to describe, issues that they're experiencing. And here I would guess actually a social worker might be a highly likely person to pull this information out. So I'm sort of guessing that you mean sort of the problem list plus the items identified by like ordering level physicians that would go in the same place. Does that make sense?
I suppose I do. I think in some sense the things that you are discussing are matters of convention, and maybe someone else on the call who's more expert in that than I can answer the questions. But the intent of what you're saying is true, right? The idea that these wouldn't be vetted only by clinical MD, NP, PA level folk without patient involvement.
Yeah, I was trying to get at that workflow piece of it. So anyone would own these items.
Yes. Yeah. And I guess the reason why I'm a little bit confused is because from a patient-centered medical home perspective, as a clinician, the problem list is collaborative for me, but that's part of PCMH principles. So that's why it might be a matter of convention, but the intent is the same. So yes. And then Bill Swan's acknowledging that from a coding perspective, according to the American Hospital Association ruling recently, Z codes are able to be pulled in to diagnoses and claims by any clinician, which is really facilitating exactly that kind of team-based engagement and collaborative care model that you're hearkening. All right, so I hope I answered your question. I did my best. Okay.
Sorry, didn't mean to get too standards oriented with it.
No, it's very helpful. And I think one of the things actually that's interesting is that we're testing right now in the Connectathon, like how we share these concepts. So that kind of comment is actually really appropriate to the testing they're doing over virtually in the Connectathon right now, right? So inadequate housing, just to continue, ZP 9.1 is currently mapped to a host of code, right? So these contain all of the inadequate housing concepts that are in the Accountable Health Communities tools, such as mold and wiring issues, and electricity concerns, dampness. It doesn't have pest infestation that I could find, but it also includes overcrowding, as was mentioned on the call last time. So overcrowding and lack of space in the house are grouped sometimes within inadequate housing, and they are coupled in inadequate housing in the American Housing Survey housing security module that I was describing earlier. Next slide, please. Discord with neighbors, lodgers, and landlord is really specific. It's just fighting with the people around you and having discontent. I did want to make sure to include it just so we could see that it is part of the housing domain of a sort. Next slide, please. Problems related to living in a residential institution is mapped to itself. And again, it's very clearly that based on the exclusion criteria for this ICD code, it's very clearly living in an institutional setting. So this would not be applicable to someone living in their own home. Next slide, please. And then this is where the things get a little bit interesting. So, hi. Okay, so I'm going to go to that comment in just a second. So we do have some SNOMED folks on the call, very gratefully, so maybe they can help answer some questions. So this last code, as I mentioned, is a bucket, like an other bucket where all the things that didn't necessarily fit in above are grouped, right? So we have on urgent housing list and on housing list, eviction notice served and eviction from dwelling, and on waiting, on waiting list, not on waiting lost for accommodation. The reason why this is important is at risk for eviction is one of the concepts that we talked about being really critical within the public health literature as we know it today. Next slide, please. And then there's just a few more. The reason why I included these is sometimes it's confusing to see the mapping. So even though inadequate housing contains lots of other things, unsafe stairs in the house is Z76.89. And then I wanted to try to do a further search just to cover some of the neighborhood concerns that we have discussed in the past. And interestingly enough, this is how currently feels at risk of crime in the neighborhood is mapped. And the reason why these are, I pulled this in is because these concepts are indeed part of the housing security module of the American Housing Survey. Next slide, and then we're going to have some conversation. So again, notably absent as subdomains in that assessment of existing code and how they mapped our concepts of history of homelessness and behind on rent. And again, just noting, because they cross other domains, the intimate partner violence concepts that we discussed last time as well do map to different ICD depending on the acuity of the concern, whether the person was injured or at risk for injury or had a history of injury. Okay, next slide, and I think this is question time. Yes. Okay. So the question, we're going to get to other folks' questions, but the question I want to ask is what came of the subject matter expert conversation was simply asking whether those ICD codes are enough, right? Do we need to ask for more at this time? Are we in the same predicament that we were in with food insecurity, where we had a really clear concept of what we needed to say, and we were very, very clear that existing terminology did not address it well? And then if so, if we do need to say new things, really thinking critically about what it is we need to say. So we have a couple comments here. So one about the SNOMED content here, and maybe a SNOMED person who's on the call can read that and respond better than I can. We do have one of the questions about whether we have an opportunity to redevelop the existing SNOMED taxonomy, and I can say that part of our submission with food insecurity did involve some changes to the taxonomy based on what we have learned, or just changes in the placement. That is definitely something you can talk about in your submissions when it comes to SNOMED. And then we have another comment here, somewhere that the housing community location is generally not safe to sleep. Oh yeah, so even though we've agreed that we're not necessarily, oh, we had the unsafe, yeah, so in this, I'm trying, so someone, Nelson said somewhere that the housing community location is generally not safe for sleep in, violence, drugs, poor maintained common areas, etc. So in the slide where I presented the rough first draft of of our suggestions at the last meeting, we did have unsafe at home as a suggested concept, and it is on the submission from to be reviewed the next round. So because we came to that collectively at the last meeting, and then okay, so we have folks can unmute themselves. I think it might be easier than having me try to race to read it. So we have Josephine McNamara. We've been talking quite a bit, which I'm very grateful for. From the capacity to be able to route patients to interventions with here is insufficient. I agree. And then we have to figure out what is next. Can we go back to that original, the slide where I presented the Z59 structure? So just so folks can go back to what we had before, what we have right now. I think folks can remember. So Josephine, do you want to talk a little bit, or Joellen, do you want to talk a little bit about that struggle? Yes, overcrowding also has health impacts, and so this is what exists right now. And then if you remember, and if we go back, actually, another 2 slides. I'm sorry. Thank you for being.
I apologize. I had my phone was muted. I'm sorry. I apologize.
Oh, is this Joellen?
I was talking away. I'm like, why isn't anyone hearing me?
Okay, so I'm just gonna. Yeah, I'm
so what I wanted to say really quick was, yeah, you're good. So what I was going to say was that the reason that they're insufficient right now is because one of the biggest differences between housing organizations and medical care organizations is that there are no general housing organizations. So if you were to code somebody with housing insecurity, or to code them generally with homelessness, it would be insufficient on their end to get any of that information unless they knew what kind of homelessness it was. You know what I mean? Mm-hmm. So from a housing organization perspective, if you were to send me a referral that said this person is experiencing homelessness, an organization that addresses homelessness on the street and shelter homelessness and domestic violence homelessness are 3 different organizations. And there is no general housing organization that would route them there. So do you guys kind of understand what I mean? Like, there are no general practitioners of housing, except maybe within, which is a growing field within the, health plans of some kind.
So yeah, I entirely agree. So part of what we do in our group is, we're trying to write this up into a paper for Al at the ONC, is work on the tension between trying to keep things simple and trying to say what needs to be said, right? So sometimes we get pushback that, do we really need new code, right? And it's the group, the community, that has to push back and say, yes, actually we do, right? No. So the thing that, so the thing that we are struck with from a data set development standpoint is we have not gotten submissions, right, for these concepts, even though we all agree they're important, right? So the things that we have currently built into our data set as it stands is we have inadequate housing and homelessness because they exist, right? At the beginning, we suggested a housing instability code, right? And we're kind of wondering whether that's even too generic as it stands, because it's just another level of a bucket, right? But these other concepts, no one has submitted them yet, right? So they exist, right? They exist in SNOMED, but we have not had submissions from the community saying it is imperative to build a history of homelessness code. It is imperative to build.
Yeah, I think it just is, again, just from my perspective, I think part of the challenge is that for the most part, the housing industry isn't involved. You know what I mean?
Yeah. Well, because they're all taking care of people with COVID.
That's the challenge. Yeah. So, well, yeah. Seriously, they are doing double time with COVID because they're like their properties are going under, and you know they've just been given a flush of funding, so they're kind of pulling their hair out at the moment. It's unfortunately it's like the worst possible time to do this for them. But and the other challenge is that the housing industry as a whole doesn't necessarily know that these codes even exist. They don't even know that these are in the pocket of physicians and providers. So they wouldn't even know to be looking to participate unless we were going to bring them in, actively search them out and bring them in, like Sheila did with me.
So this is the continual, I'm not going to say battle cry because I'm a pacifist, but this is so one of the complexities of doing housing right now is that our policy friends, right? National Low Income Housing Coalition, Healthcare for the Homeless, they are really 100% consumed with trying to take care of a national crisis, right? So, so we do have public health folk who are not necessarily clinicians who are part of this, right? But one of the tasks that we have as a community is really to try to see if the relationships that we have with community-based organizations that are working on these kinds of concepts can help lend insight to the desire to get this right, right? So Sarah DeSilva sending out an email to, a listserv is not the same thing as Joe Allen from UHC reaching out to the folks that you know and work with every day, so I guess we've represented this in a bunch of different ways. So the idea was the last time we met, we talked about what needed to be said. And some of the pushback was maybe we don't need to say new things. And then we bring it back asking that question. And it's clear, I think it sounds, so we have maybe do one-on-one with housing SMEs. We do have, so that I'm meeting now, and Rich can testify to this. And Allison's on too. Hi, Allison. So Children's Health Watch is very engaged in this problem right now, but because we are like a cross-sector community, we do really need to ask the community these questions as well. So we can't have subject matter experts deciding these things over here and then not involve you all. So any other thoughts on this? So am I right to say that if we go to the next slide, and then the next one.
Sarah?
Yeah. Oh, sorry, back one. Sorry, Linda. Yes?
This is Lucy.
Hi, Lucy.
I'm wondering how to handle this this understanding that you have conveyed and that others have conveyed, that the issue of adequate housing is not a very well organized sector, shall we say, in terms of nonprofits or government or public-private, whatever. This group has materialized from a clinical health sector point of view, and wanting to address housing as a health risk factor has now bumped us up against the housing sector, which isn't very well organized. And what could we say that would be helpful for patients, helpful for clinicians in terms of referral, or helpful for researchers in terms of delving into healthcare records to discover just how prevalent or acute housing issues are. So I'm thinking that we have a task to do, and we come at it from a point of view, and ultimately the best we can do is to try to grapple with it from the health sector point of view, knowing perfectly well that housing experts might look at our ultimate decisions and say they don't know what they're talking about, or how could they do this, or why didn't they invite us? And there are 88 reasons to answer all of those questions, but ultimately, our point of view is how can clinical care grapple with this? And that's what we need to decide. We can't answer every single question that a dedicated housing advocate could possibly want us to answer.
Julia, my comment was going to be, you know, to the earlier point about being actionable and also to my point about fitting into the workflow. I'm not saying that any of these codes are not necessary, but I think we want to think about, you know, do they add value to the team that's on the ground in terms of understanding and being able to take the appropriate action? Or are they adding more burden in data capture and entry than they are necessarily adding in terms of actionable value?
Yeah, so that is absolutely 100% attention that we go back and forth with all the time, right? It's like there are those in the Coding High Achiever Club who want every single granular code, and then there are those that just want to be able to get through the day. I do have to say that the codes and claims are so vitally important, right? So Joan's right to talk about linking with interventions, because you know every referral I place as a clinician has a diagnostic code on it, right? Every order I order, if we again and we talked about this last meeting, like if we're trying to represent risk, you know, everything we know regarding the risk of housing concerns on health outcomes, like significant. Like if we're trying to represent risk beyond homelessness and inadequate housing, of which there is a lot, right? We do not have a way to represent that risk in claims that can then be analyzed from a population health perspective. So I guess, so we have a bunch of further meetings with subject matter experts regarding this predicament. I suppose I'm going to ask a direct ask from anyone who'd be willing to help connect with community-based organizations and housing folks, that you write me, right? And we acknowledge the complexity of this time from a COVID perspective, but really create a little micro strategy on trying to get things in front of the faces of people, even very briefly, just for a face value assessment. This is Sarah DeSilvi. Hi. So someone's asking who's speaking. My name is Sarah DeSilvi, and I am the clinical social determinant of health informatics lead for the project. I will totally provide an email. My email is usually all over this, but I'm going to type it into the chat. Because I really want to make sure we get this right. So if folks are willing to reach out to me individually, then maybe we can form a small working group just on facilitating engagement. And I do want to say, I want to acknowledge in this work the investment of HMIS experts in this work. So early on in our work in March, and some of you who have joined more recently might not have been aware of that, we put out a call to have folks who are fluent in HMIS do a mini work group on making sure that HMIS concepts were married into our data set. So they've been very involved, and I'm very grateful. I don't know if any of those folks are on the call. So we have another highlight. Mike Klinkman says, as a clinician, we will be using Z codes when creating referrals. We need an improved ICD set of codes, probably not SNOMED, to document that on the medical side and link to the community. So, so those of you who are willing, please reach out to me. I am at your service, and we will try to figure out how to reach out to our CBO groups. Next slide, please.
Sarah?
Oh, yeah?
Can I, this is Joellen. I just wanted to jump in really fast. I just wanted to to give some relevance to, the focus on some specificity around the housing, because I'm not sure if everyone recognizes this, but when hospitals do their, once every 4-year survey for their community survey around their distribution of nonprofit funds, affordable housing and housing issues consistently rates the very first issue for every hospital around the country. So this isn't something that where housing is trying to needle their way into medical. This is the reality that this is the direction that everything is going. So the better we can do with these codes is going to be beneficial to everybody, not just individual practitioners, but hospital systems and everybody else, because it's bubbling up whether you want to focus on it or not.
Well, and I think the intent of gravity is that we do. We just this is why we exist, right? It's resting on the burden of evidence regarding social needs and their impact on public health outcomes, and the understanding of how everything from health outcomes to the financial bottom line, right? So the ear of the health systems and the clinicians are definitely they're attentive to this. We just have to make sure that we get to a point where we figure out at least that one extra code we might want to say. And in the beginning, we did suggest just that housing instability code that might be a little bit more granular, and add something more specific than other problems related to housing and economic circumstances, and we can revisit that. Next slide, please. And then if we can click all the way to interventions, you'll see this theme again persist with interventions. I don't think we have to necessarily go through it all, because we really are closing in at our end of our time. So one more comment. Yeah, so one more comment. If some of these more specific codes are nested under a grouper, that might be a good terminological approach. So that actually was the intent of that housing instability code, right? So it's more specific than other problems related to housing and economic circumstances. But it would contain a bucket of codes that are currently not represented in the groupings in ICD as they stand right now. And then that was so one of the things I think we can consider is what that grouper would be, right? Again, because certainly having critical things like risk for eviction in the generic bucket for the whole set of problems related to housing and economic circumstances means they're lost. That's even more lost than lack of adequate food and safe drinking water. Like that, it's the bucket for everything. So there's not really enough there if that's where they stand. So interventions, programs, and agencies. Any other questions? I want to make sure that we could even create subgroups. Yes, we could. Yes. Grouping in this domain will be a little tricky since there are more than one organizing principle. I would love help. That sounds fantastic. I just freely gave out my email address in the chat. This is my labor of love. So I would love to coalesce anybody who wants to deep dive on this. Next slide, please. The reason why I put this out as well is I am enough of a social needs clinical intervention person that I know that we're missing concepts here as well. I'm just going to submit them after reflection myself. This is part of how I start to drive conversation here. But if you look at what we have submitted right now, housing counseling, lovely. So we have professions we're referring to: case manager, care manager, social worker, community health worker. And community health worker, I want to note that we created as part of the food insecurity build because it wasn't there the way we use that term in U.S. social needs interventions. For agencies and organizations, we have housing agency. We don't currently have medical legal partnership and legal aid, and then we have Josephine. We're gonna, if we can create, we're gonna take the chat and capture it. And if people are writing in agencies and organizations, I will add them to my to the submission and bring it back for adjudication. We do have community action agency, we have benefit enrollment assistance, and we have coordinated entry that came through the HMIS submission for provision. And again, sorry, the tables are wrong there. Where I've submitted one to be reviewed next week, which is a housing voucher. But this is what we have for this. And then, so yay, community health workers. I know, I'm so glad to see community health workers on the list. As a rural patient-centered medical home, community health workers make my world go round on a daily basis. So, so next slide, please. And then we do have, so far, as part of the HMIS Health IT work group, each of the HMIS, each of the HUD housing program types, because oftentimes the evaluation of program eligibility is happening through partnerships in healthcare settings. So we have yet to adjudicate it, which is why everything's all gray. But I do want to let everybody know that this is currently in there. But the thing that I'm recognizing is that the HUD housing program types don't include all the ways that we intervene on housing, or they might not include all the ways we intervene on housing in clinical settings, because there's many, many innovative partnerships that are going on with healthcare and community partners that might not fit into the traditional HUD model. Lucy says legal belongs in professions. So Boston Hospital introduced it 30 to 40 years ago to help. Certainly. So we, instead of just referring to an organization like Medical Legal Partnership or legal aid, you might refer to a lawyer who, or is that what you're saying? So the profession itself would be in a referral. That's interesting. And I think we might consider that. Next slide, please. There. Okay, any questions before we on this? So we should add RNs, community nurse specialists, help with housing. They're not necessarily care manager, case managers. So I'm as a nurse. So Christine, do you want to, myself, I am a nurse. So Christine, do you want to unmute yourself and talk about that role a little bit?
Sure. Before my current career, I was a community nurse specialist at a state hospital, and my clear focus was discharging patients into the community. As the community nurse specialist, my role was to find apartments, find group homes, find nursing homes, find apartments, find any place I could to help people with housing, and then visit those people as they were in that housing, and identify needs if they needed to have help with that housing or maybe move to different housing. So that's what I was thinking of.
What a wonderful job. All right, so we'll put that. So everything coming in the chat will go through the community, the adjudication process, and come back to the community for review. Additional interventions are housing payments, payment supports that go to housing ownership wealth creation through vehicles like shared equity development, community housing loan supports. Good suggestion. So I put the housing voucher, but that is a little bit different. So one of the things that happens, again, just to let you all know about the future. So we're in this like bring it phase where we just get all the different concepts and we throw them, we adjudicate them and put them on the master and talk about them. And then we start to discuss as a community, we go through this end-to-end review process eventually where everyone starts to comment on the submissions and offer slight tweaks, right? Actually, this should be said this way. So the ideas are what matter right now. We can refine names and program types and conventions in the future. The thing to know is that every single program type we define, or every single person we define, we need to, define in a concept, we need to define with the conceptual definition. So part of our work in building the terminology and then eventually building it into data standards is we need to be able to say, this is what we mean when we say X. So we'll take these concepts that are in the chat and then put them in a submission, and it might mean that we wordsmith them together over time if we don't get it quite right. the first attempt. Any other questions? My Lord, 4:54. Or should we? I think. Wow. Okay. So organizations, community development finance institutions. I love this. I love this. Okay. So again, we'll take this chat and I'll work all of these different concepts into submissions, and then they'll go through the adjudication process and then come back to the community. I want to take a moment to thank everybody. There's a quick next few slides. Care navigators and patient navigators. Yeah. So exactly. So we'll put that in there. We talked about care navigation and care navigating and the care navigator role with food insecurity, but it might be important to bring that back up again. So one huge thank you to everyone for being willing to have this conversation today. I'm going to specifically say again, so next steps, Linda's helpfully taking us through as we walk down the end of the meeting. My email is in the chat. I am hoping that folks who are able to help us connect with CBOs who are necessarily preoccupied with very pressing needs right now, they can contact me and then we can try to figure out an outreach plan. That would be lovely. Any other thoughts before we close out our meeting? We have another call for healthcare navigators. You're welcome. Oh, yeah, thanks all. Great info and discussion. I feel we're coming together and moving forward. It's an interesting process. I really do feel that there's this collective knowledge crafting that we do for a while, and then eventually it coalesces into shared language, which becomes our data set. So I'm very, very grateful for all of your attention on this lovely day. It's the first gorgeous day in Vermont in a long time. It's been gray. So any other questions before we go? Again, I want to encourage anyone who is on the phone call today to become a member of Gravity by going to the Confluence and signing up as a member. The Confluence has all kinds of information. We're including links to all of the screening tools and the literature that we use to drive our work. You can find the schedule of all upcoming meetings, and you can find recordings of past meetings to review things that we've discussed in the past. And I definitely want to ask folks to download the next copy of the master when it comes around. There's a version of the master right now as it stands on the Confluence, which is a good reference, because that is the thing we make together, right? So having everyone take time to review that master so that we can discuss concepts when we come together on our calls is really important. We have, oh, great. Okay, lovely. So this RDNs help us case managers too, so I'll try to talk to my community and create a concept. Lovely. Thank you all. Any other thoughts before we close the call?
6 inches, right? Now, what about at the very top? See the very top?
Oh,
very top, third.
I think that's someone who's not intending to talk on the call, unless. Thank you all for joining. We look forward to seeing you in a couple weeks. I really look forward to seeing my inbox light up with folks who want to work with me on connecting to CBOs and folks on the ground. And you all have a lovely Thursday evening.
Good. Thanks, Sarah.